A very good afternoon to one and all present here. It's been a great honor and pleasure to be here among the Doyens, and we have had a fantastic lecture by Dr. Padmashri Mohan sir, and then we also had a lot of other insights. And I'm going to take it quick because I know it's lunch time, so I just want to make it as short as possible. So we are going to talk about the improving glycemic outcomes and new generation insulins, because we know that recently there have been various circulations saying that the old generation of insulin is slowly coming down, has been withdrawn. These are my financial disclosures. This talk is for Novo Nordisk. Looking at the typical case scenario in our day-to-day clinic, we see one 49-year-old gentleman engineer which has 9.5 as HbA1c, fasting is 196, postprandial is 244. Already he is in diabetic for the last 7 years, and now he is on metformin, glimepiride and empagliflozin, which are on maximum doses. So what do we all do in these case scenarios? Especially in an Indian scenario, we all know what we usually do. So what happens is, like, we keep adding OHAs until we get the control because of inertia to start insulin, or most of the time the physician itself is having an inertia. But what the literature says is very clear. As you keep adding more than 2 OHAs, you only get a decremental effect. Even if you have an incremental effect, it might not sustain for longer period and the patient continues to experience hypoglycemia. And when you add insulin to these patients, when you have more than 3 OADs, you always see a good reduction of HbA1c. So successive oral anti-hypoglycemic drugs has a lessening effect in most of these patients, and substantial benefit could be obtained only by initiating insulin, which we are all well known is already in the guideline, but we have a little bit of inertia to start those. When you come to insulin, so then if you convince the patient to take insulin or you start them on insulin, so what next? If you can see that the unmet needs, most of the guidelines says that you start on a basal insulin. So previously, back in those days, we had this insulin of NPH. Still we continue to use NPH in government setups, still we continue to use, and even in government setups off lately I see that people have changed into the newer insulin, first generation. So when you see the first generation, it was really not once a day, it always has to be given 2 times a day or sometimes 3 times a day. Higher glycemic variability, it keeps peaking up and down. Fixed timing dosage is the key in most of these generation of insulins which were not there, especially in the current generation where we do not have time to take care of ourselves, but we have time for everything else. So not truly a peakless insulin. So this is what the inherited risk we had. So coming to the current basal insulin, if you see there are in 2003, you have the euglycine, which is still continuing to be used by most of us, and then we have the detemer, which is still be used in pregnancy, and now we have heard that detemer is going to be withdrawn. And then in 2013 we have degludec, and then in 2018 we had U300. The previous insulin was always at half-life was around 5.5 days or half a day. But the newer generation proceeds, it's a truly peakless insulin which proceeds more than a day. So when we come to the degludec and when you compare U300 glargine, both are a single dose. They say that there is no glycemic variability, but the study otherwise says that the euglycemic clamp study in type 1 diabetes which was done, it clearly shows that the effect of degludec, when it is given at 0.4 units per kg, you don't see an intraday variation. The time interval between these are flatter. That means it's a truly basal insulin which mimics the physiological concept of our regular body. Whereas when you come to glargine U300, you can always see a dip. First it starts acting only after 6 hours, and then you can see that it goes low, and then there is a much intraglycemic variability in most of these cases. Again coming to degludec, higher HbA1c reduction. Here I can see that it is 1.5 and 1.2, but if you see it is statistically significant, you have better reduction because there is intraglycemic variability is less in these patients. So again, coming to degludec has a lower risk of hypoglycemia in most of these patients, and you can see that when it's compared to both of this, you can see the rates of hypoglycemia demonstrates nearly 30% lower reduction of hypoglycemia compared to a euglycine 300, and then the change of preposition of patients experiencing more than one episode of hypoglycemia was also significantly lowered, because when you come to insulin, one thing that the patient doesn't want to experience or the fear the most is a hypoglycemic episode. If you have a hypoglycemia, probably the patient will never come back to you with the insulin, or they fear for it, where we have to spend some extra time to make them understand, and in our busy practice it is nearly impossible to spend more time with these patients. So it not only that, it also says that when you shift to U300 glargine, there is always a 20% extra dose which is need to be injected, though the volume might be less, but the doses are always high. This I have experienced myself in my clinical practice, and I am sure that many of you who are using euglycine 300 will also experience this. And when you come to dose flexibility, which we talk about most of the time in our regular patients, why dose flexibility? Today if you see, the patient says, sir, we don't have time, we have night shifts, we have morning shifts, we forget it. See, they will be on time for a movie, they will be on time for everything else, except for the course that they have to take the medicine timely. So most of the times, even in households, you can see people, our mothers who cooks the whole morning, they continue to cook, they forget their medicines, the time is up, and then you keep adjusting it. So this is how it is. But when you have degludec, you have at least 8 to 40 hours of dose flexibility is allowed. When it comes to euglycine 300, then it can be up to 3 hours. In this case, we revisited. We started the patient on degludec, 14 units, and then we saw after a 3 months period, we saw a subsequent reduction in these patients. The patient is happy. We reduced the number of OHAs, and patient went home well, and now he continues to be still under control. So let's look at the next case scenario, where you have a 53-year-old gentleman, 10.2 HbA1c, fasting is 150, postprandial is 280, and in this case again the patient is on 3 OADs of a maximum dose. So when you come, Dr. Mohan has clearly stated in the last few lectures that we were once a poor country where we had 1 meal a day. Now we have been having multiple meals a day. We are compulsory snackers, food is available everywhere, and we have a huge carbohydrate load. That's what Dr. Mohan finally finished his slides with, saying that at least 15% of your carbohydrate level should come down, which we try to tell these patients most of the time. It might be practically not possible for us to tell these patients, because we've been advocating this quite some time, for a long time, saying that you have to add more proteins, but we don't tell them what more proteins are. We tell them cut down on carbohydrates, instead of 3 idlis take 2 idlis, but somehow if you see the total calculation throughout the day, the average patient consumes around 300 grams of carbohydrate every day, which is quite high. So in this case, a basal insulin alone might not be a popular one in among our cases, because we have a high carbohydrate load, so that we need to hit the postprandial high. So most of the time, if you see that though increase in postprandial and fasting plays an important role in HbA1c, if you see the postprandial is the one which plays the maximum contributions towards that of HbA1c, and this is what we are going to talk about next. So if we have in this case premix, or a premix or 2 combinations of an analog is only available as degludec and aspartate. In the whole world there are only one product which has 2 components together, that is 2 analogs together. All others are either protominated insulin or probably has a different component. So in this, when you start insulin naive patients from basal insulin and compare that with the premix, you can see that the HbA1c reduction was superior from baseline, which is 1.4%. You had a significant reduction of postprandial component, which is very relevant to our case scenarios, where we see on day-to-day activities, we see our postprandials are high. In my practice, sometimes patient comes and tells me that the lab reports are wrong because the postprandial is lower than the fasting. So this is how we see most of these patients. And you can see that there is superior reduction, and up to 72% of these patients are able to achieve targeted HbA1c. Similarly, when you have multiple OADs, the chances of hypoglycemia and hyperglycemia are quite high. If you see people who are taking 4 or 5 drugs, they continue to spike. It goes slower, it goes higher. They start eating more when it goes slow. When it goes high, they are worried, they take more number of medicines. So when you started these patients, the confirmed hypoglycemia initially at baseline was 176, but over a period of 3 to 12 months, it was nearly negligible for most of these patients. And then severe glycemia almost nil. So not only did the sugar comes down, but the quality index, that means the patient satisfactory quality index, was significantly higher because they have better controls, they have less number of tablets to take. If you see the overall cost, it is still lower than how many medicines you take every time and the hospitalization cost. So there was a better index of all these patients. So from basal, where we started, the euglycine 100 said, any time of the day, but same time every day. Then the U300 came, it said within 3 hours before or after injection, and now you have this injection which you should give at the major meal of the day, which says administer any major meal of the day. And in our country, most of the major meal of the day, though we say that you eat like a king at breakfast, eat like a peasant at lunch, and then you eat like a poor beggar and in the night, we always follow the opposite. If you can see, it is always the king's dinner that we eat. So most of our patients have the high carbohydrate load, so this is more flexible to us. And then the recommendations are very simple. How do you titrate it? In my experience, though the slide says that it's once major meal a day, in my experience, I have always used it twice. There is no doubt it's a premix insulin. There is no doubt it's a 2 combination insulin, and it works best when you give it twice. So either you can base it on a major meal, yes. If your fasting is higher, how do you titrate it? That's the next question. So the titration is very simple. When you give it in the night, you titrate according to the fasting blood glucose. When you give it in the morning, you titrate it according to pre-dinner. So pre-dinner if you give twice, then you can titrate accordingly, and it's very easy. And we have been using this premix, and the number of pricks comes down, and patient doesn't have any hypoglycemia, and this is the whole idea behind this particular molecule. So when it comes to intensification, when do you intensify? When do you need to try it 2 times a day? When you have a dose, higher dose, 30 to 40 units you reach, you are still unable to achieve the target, and there are spikes at dinner or at breakfast, and you are not able to give it once a day, then you split it. So it's as simple as that. So when the total dose, you can always split between 2 meals, and the ratio of the carbohydrate content and the amount of carbohydrate, if you can sit and calculate by a simple monitor, you will be able to do that. And finally, coming to my last slide, the simple concept is, we have been, Dr. Arvind has clearly stated, people want to buy cars, people want to build houses, people want to do a lot of things. They want a fancy mobile. And Dr. Krishna Seshadri has also pointed out very clearly, less than 2.3% were among the priority. So today, affordability for health is there among patients. All that you need to do is to convince them that it is your topmost priority. As physicians, it is our responsibilities to tell these population, tell these people that you have to varumun kappom illa vandadukapram pappom. So this is what is the slogan. So the better option is varumun kappom. We will prevent diabetes. We will try to make sure that we can try to give these insulins or convert more. It's not a promotion to convert more number of people into insulin, but to do the right thing at the right time. Thank you so much.
So we would